are you looking at, these aren't going to be the patients that are going into skilled nursing facilities on Medicare, correct? Though it would be the patients that are going directly to long-term care in a nursing facility or looking to go out to a home and community-based service, because I would say that 90% of the patients are going either to a skilled home care service from the hospital or a skilled Medicare bed in the skilled nursing facility. At that point, none of this applies because it's a skilled set with Medicare on home health going home or a skilled nursing home bed. It's not a home and community-based service whatsoever that the hospital's dealing with. And that would be the great majority of the patients.
Anyone on our team want to address that? Are you suggesting that we should approach Medicare and introduce the universal assessment process or a screening tool also for those placements?
I think that would be very ineffective due to the fact that at my facilities, my skilled nursing facilities, over 90% of the skilled nursing facility patients that enter my facilities go home independently after rehab. And so you have, let's say, 50 patients come in your building, maybe only 5 of them would stay long-term care or in the nursing facility. The actual assessment is going to have to happen, I think, on a pragmatic level in the skilled nursing facility, because they may come and be there for 30 to 40 days in the skilled nursing facility, and that's where, from the acute care setting in our world, where we deal with it, and we actually need help. Some of our skilled beds or we're trying, there's patients that are tweeners and we're trying to get them home. They need just a little bit of support, and we would welcome more resources to get them back out into the community. And that's where, but it may be 50 days after the initial hospital stay.
I think we can take what's proposed and meld it into what you're suggesting also, because I see that there will be 2 different patients that we're looking at. We'll be looking at a skilled patient needing complete wraparound therapy and nursing services the first 50, 40 days. And then you have another resident. You have someone that needs the placement in the community, or they need continued nursing care. They need continued, maybe not skilled level, but they need nursing home level of care. So I don't disagree with you that we may have some need for a step-down evaluation once that person goes off of Medicare. We would have that information in the MDS and would be able to pull that, but we certainly could incorporate a notification from the facility that they're coming off of Medicare and we are seeking the next level of evaluation. I think that's something that can be built in. We have other experts here that can give their opinion, but I think it's something that would be needed.
And one other quick statement with our friends, the hospitals are very sensitive to their length of stay and are very aggressive working with us trying to get them into our skilled rehab beds for rehab because of their length of stay. And I feel like that we need to look very closely at having someone working in the acute care setting that is getting a benefit from getting the patients pushed out of the hospital, doing the assessment of where they go or how they get out. Because I don't want to take a patient in my facility that doesn't qualify and have them there for 30 days taking care of them, and then I don't get reimbursed for providing the services.
I would just like to make a point. I'm Krista Hughes with the Division of Aging and Adult Services. Back to Dr. Beverly and David, what you're saying. The assessment, and again, the decision is not made as to who will complete that assessment in the acute care setting. As far as I know at this point, our conversations have not been there. But I do want to point out that the assessment, the assessor is not determining eligibility. And I think that's a very I mean, y'all really need to get that the instrument itself has the algorithms that are being built that will be audited back to ensure that they are, in fact, making that correct determination, but it is not in the hands of an assessor to do that.
Here's a picture of what we currently reimburse this is on the nursing facility side. And again, one reason you see the nursing facility data and not the community-based survey data is we can't break the data down yet in this way for community-based services. We will. That's part of the process. And then we'll put the same pictures up for community-based services as well. But here we see the level of need. So what you see across the bottom here is the RUG levels. And then the average payment for those that we reimburse within each RUG level, the average payment to the nursing home on their behalf. And so you see at the lowest end of the RUG level what our average payments to nursing homes are. And then you see at the highest end of the RUG level what the average payment to nursing homes is. This just confirms what we have said earlier. We don't design the payment right now to match the level of need, therefore it doesn't. And this is just one way of showing it. Here's the number of clients within each of those groups. Some of them are very small and almost don't even show up. You could multiply the two and get the total dollar amounts. But I think it's the upper well, actually, the issue on the bottom, how can I get out of this? There we go. The issue on the bottom is, we have a fair number of patients or residents that we're reimbursing in these levels. Again, the point that we were making before, and also the point when we have the data for community-based service recipients, we'll put the same charts up, and it's really both that we're addressing. An implication of this is that it does not pay off for nursing facilities, at least for the Medicaid patients, does not pay off to focus on the upper end. That may happen. We may get donations from nursing homes in that regard, but there is not a business model based on Medicaid reimbursement that supports a focus on high-needs patients. That's also true in medical care. That's true across the medical spectrum and in Medicaid. We do not currently support business models that focus on the highest needs patients. So a common theme across all of our areas of payment improvement is fixing that, because that's where we think the greatest payoff in health and spending is actually enabling. I talked with with a policymaker recently about the patient-centered medical homes. Same thing. We do not pay primary care providers to focus on their high-needs patients. So guess what? They're not able to. They'd go out of business if they chose to. That's part of the goal here, not only in nursing homes or community-based settings, but also for primary care. Another way of showing this is the following. Here are two hypothetical, they're not all that hypothetical because we have the full spectrum in the Medicaid program, but two hypothetical providers. And what you see for the provider on the left is the distribution, the percentages of their patient base that we're paying for at each level of need. And so you see this on the left-hand side. That provider has more who have a lower level of need, and that distribution is focused to the left, and yet our payment is that per diem in the middle. And on the right, you see a hypothetical, but probably not all that hypothetical, nursing facility with a concentration of patients at higher needs, and yet the payment is exactly the same. It's just another way of showing the result. Under the current system, provider B receives the same reimbursement level as provider A, despite having much needier clients, and there are examples of this across nursing homes today. To ensure that nursing facilities are reimbursed for higher cost clients, reimbursement would need to be adjusted for their higher needs. And so an example of reimbursement current versus future, that's what this chart shows you. Currently, reimbursement is at that same level. This is just the upper part of that chart. Across levels of need, the average reimbursement is the same. That's the dotted line across the middle. So what if a nursing home had patients across the spectrum? They'd be saving money on some patients and spending money on others. The problem is we don't have a uniform distribution of need across all nursing home providers, so it comes up very unevenly. We have some who are overfunded and are essentially making money because of the lower level of need in their population, and we have some who are underfunded. They're losing money because they have high needs patients, residents, and it turns out we have the data to fix that. I mean, it is possible for us to fix this and instead have as the solid line shows, a payment that's actually proportional to the level of need according to the amount of resource that's required to serve each of those needs. And that's our explicit goal. Have we come up with that formula yet? No. Is this a policy decision that has been made? No, not until the legislature and CMS review it. And certainly we won't even bring it to that point until you all have walked all the way through the process with us. We'll show you that time frame, remind you of that time frame in a minute. But we want to be transparent in where we're heading so that you have, as stakeholders, the greatest opportunity to contribute, steer us in a different direction if that's where we ought to go, help us to better the direction as we move along. How do we determine need? This becomes critical if that's how we're going to pay. Mindful of the fact we couldn't do any worse than we are now. And that's what you see here. The RUG-4 is the leading severity grouper for case mix adjustments in long-term services supports. RUG-4 is the most recent version of the resource utilization group, widely used as the case mix adjustment standard for long-term care in the U.S. The RUG-4 case mix system is based on the results of ongoing analysis of nursing home staff time measurement, which is collected in the Staff Time and Resource Intensity Verification Project, 05 to 10. Strive. This is full transparency, folks. Statistically robust with increased accuracy, that is 4 versus earlier versions. 13 new RUG categories have been added, bringing the total to 66. Categories are split to secondary and tertiary levels. You know, those of you familiar with hospital payment, this is the same kind of severity adjustment process that's been happening in hospitals over the last 30 years with the development of DRGs and then MS DRGs, and where are we now? Something beyond that. APR DRGs, you know, the lists go on for severity adjustment. And it's more accurate. The data set's based on 10,000 observations over those 5 years from over 200 nursing homes. And these observations aren't just taking the MDS data. This is resource, you know, time and motion, time studies, et cetera, within the nursing home. Very, very intensive effort. And you can see how widely used it is. Case mix states outnumber, it looks like, the non-case mix states. Although the new payment model won't go into effect until 2014, full disclosure, it'll be based in part on data that we're collecting between now and then. So this is a Gantt chart or a timeline that just says, first, the time frame that we will use to collect data to develop a new payment system, which begins essentially now but could run all the way into next year.